Let's get started. So good morning again. I think today what we're going to do is, right, let me just figure this out. Minimize. So we're going to look at intracranial hemorrhage, and I've kind of targeted it more from a neurosurgical perspective. What I'll do is turn the video off now, but hopefully you're still able to hear me all right. And let me minimize that as well. Okay. So no disclosures pertaining to this talk. I'm going to roughly talk about it in two sections. So the first half hour or so, we're going to look at trauma. And then the next half hour, also maybe say 25 and 25 minutes, we're going to look at the next 25 minutes, we'll look at spontaneous hemorrhage. And what I would also like to go through is approach to the workup of intracranial hemorrhage. And we'll do this mainly as a case-based approach. And, and predominantly, in the context of spontaneous hemorrhage. So that's the basic outline. Any questions that you have, please type them in the chat box towards the end of the talk, because, as I said, I'm not able to see the chat box once, I'm sharing this screen. And also what I've done is just to break the monotony of the talk, I've put in 2 or 3 cases which are more interactive. So asking you a couple of questions. Again, in that case, if you type the answer in the chat box, I think Tanveer can read it out to me. Okay, so let's get started. So as always, in the context of hemorrhage, what would be the initial modality of choice for imaging? So for example, if we look at CT, we know it's fast. There are really no contraindications for non-contrast CT. We've got to be careful when we're imaging children. But, again, that's not a contraindication. It's more assessing the risk benefit in kids. But otherwise, I would say there is no contraindication for a non-contrast CT. It's readily available. I mean, every center has a CT scanner or more than one CT scanner. And I would always say that there is a relative ease. So I'm very careful in using the word relative here, because yes, it's not easy to image unstable patients and certainly not easy to image ventilated patients, but imaging makes a difference and it is necessary. And therefore, if we look at CT versus MR, relatively it is a bit more easier to image these patients with CT. And finally, it's accurate. So what are the stipulations with MRI? It takes time. I mean, you can get a CT head in a few seconds. MR is going to be at least 15 to 20 minutes, even if we do a fast MR with the most basic sequences. There are contraindications, and there are quite a few contraindications. Not readily available out of hours. Certainly a lot of institutions don't provide MR service out of hours. And it is unsafe when the patient is unstable. If the patient is ventilated, it is quite a thing to get an out of hours MR, because you need to have not only a patient who is MR compatible, but you also need to have the anesthetist who is MR compatible. I mean, as in who knows what to do. You need to have all the equipment that is MR compatible. And we need to have radiographers who are trained to do MR compatible imaging. So that's why it's not really safe. And finally, there are pitfalls of hyperacute hemorrhage. With all the sequences that we have on MR, the sensitivity is no less than CT. In fact, in certain cases, the sensitivity is even higher. But there are pitfalls, and we'll look at a couple of cases in this talk when we talk about pitfalls. So let's start with trauma. Now, there are 2 major categories when we talk about traumatic brain injury. So first is the primary injury and the associated primary complications. So this is a consequence of brain damage that is happening at impact. So what are the manifestations? Contusions, intra and extraaxial hemorrhage, and diffuse axonal injury. The second thing is the secondary complications, which are not present at the time of injury, but these are a consequence of the primary injury over a period of time. And these are very important as well. So when we talk about these, we're talking about raised intracranial pressure, brain herniation, infarctions because of brain herniation, hypoxia due to the raised ICP, and also infection. Now, because we've in the last talk, we kind of looked at detail in brain herniation, I'm not going to redo that. I'm just probably going to show 1 or 2 slides on brain herniation because we've already touched on that. But these are the important things that we think of. And I usually, when I talk to radiology trainees, I tell them that it is not just important to document the primary injury. It is also really important to evaluate on imaging what the features of secondary complications are and to document them. A brief recap of the anatomy of the meninges. I mean, you're all neurosurgeons here, so I don't think I need to go in detail about this, but this is an image from Gray's Anatomy. And I really like this image because I think it answers, or it allows the understanding of the different patterns of hemorrhage quite well. So this is a cross section. This is a coronal cross section. So what we're seeing here is the calvarium. We've got the dura, which is in yellow, and the superior sagittal. So this is at the cross section through the superior sagittal sinus. So we've got the superior sagittal sinus here and the dural reflection of the forks. What it illustrates is the fact that pia, which is in red here, closely invests the surface of the brain and dips down into the sulci. The arachnoid overlying it is, loose, and we've got a space between the pia and the arachnoid where we see all the blood vessels going through, or the subarachnoid space. And then we've got the potential subdural space between the dura and the arachnoid. And coming to the dura itself, we know that there are 2 layers of the dura, and we've got the periosteal layer, which is very firmly adherent to the inner table of the calvarium and which also invests itself at the sutures and reflects down along the forks and along the tentorium, and the membranous layer, which is the second layer of the dura. So I'll stop over there. As I said, I don't think I need to go too much into detail about the anatomy here, but I think this is important, and we will understand the importance as we look at the images of the different hematomas. So let's start with an extradural or an epidural hematoma. Now this occurs because of hemorrhage between the inner table and the periosteal layer of the dura. The usual underlying etiology is because of a fracture and causing vascular injury to the middle meningeal artery. So that is by far the common mechanism. But it can also occur when there is injury to the venous structures, either the middle meningeal vein or the venous sinuses or the diploic veins. Now, important thing to remember is that in children, we can see extradural or epidural hematomas because of vascular injury that can occur without fractures. So what do we see on imaging? The common location tends to be more temporal and parietal region, mainly because of the fractures going in the involving the temporal and parietal bones, but it can occur anywhere. One thing to look for is an associated fracture. And if we see an associated fracture, we need to be really careful in looking at the hematoma carefully and deciding whether it is an extra or a subdural. Usually what we see is a biconvex extraaxial lesion. And the reason it is biconvex is, as we've discussed in the anatomy, that's because the periosteal layer of the dura is very firmly adherent to the calvarium, so it needs a little bit of force to strip it off. That's why we see a biconvex appearance to it. And again, because the dura is invested in the sutures and doesn't cross the sutures, the hematoma, extradural hematoma, also will not cross the sutures, but it can cross the midline. So when we see on CT in the acute phase, what we see is a high density or a hyperdense biconvex extraaxial lesion. Now in this patient here, we're also seeing fluid level. So we can see areas of low density above and we see high density below, and we actually see a nice straight level there. Again, another level. This is an extradural hematoma that was imaged as the patient was developing it. Okay, so this is active bleeding. Now, the reason the hematoma is acute hematoma is dense on CT is because the blood has clotted. So it is the clot which gives the high density to the CT. So therefore, when we have blood which is still bleeding or extravasating and not yet clotted, we will see fluid levels. One of the other things to remember again is if the patients are on anticoagulants. Okay, so typical example of an extradural hematoma. In this case, we also see the secondary complications. So we see mass effect, we can see subfalcine herniation to the right. So what about a subdural hematoma? So subdural is when the hemorrhage occurs into the potential space between the dura and the arachnoid. And this is a venous hemorrhage. There are two groups. So the younger group, wherein the context is usually that of trauma, and you see an acute hematoma, and the elderly, where we may or may not have the history of trauma. Subacute presentation can be a chronic presentation as well, and usually occurs because of rupture of the veins that are tethered because of brain atrophy. And when these veins rupture, we can see subdural hemorrhages. So what is it that we see on imaging? So this is a young patient and in the context of trauma. So usually overlying the convexity. Now they are again extraaxial by definition, and when we see a hematoma, these are concave inwards because remember these are occurring into the potential space. They don't have to, they need not be, so it is not like the extradural wherein you need a substantial force to push the periosteal layer out. So this is actually subdural. That's why we see a concave inwards. And if they are large hematomas and if they're occurring really acutely and active extravasation, you can see a convex inwards subdural hematoma, but this is quite rare. They will cross sutures by virtue of their anatomy, but they do not cross midline. The reason they do not cross midline is, as we've seen in the slide on anatomy, the dura will turn reflect inwards as the forks, and that's why when we see a subdural coming in towards the midline, we see that it turns inwards along the forks as a parafalcine subdural. So in this case here, we see a high density extraaxial abnormality causing a lot of mass effect, and we can see there is subfalcine herniation to the left. Again, there are areas of low density within this. This was in the context of an acute trauma, so this is more likely going to be unclotted blood or active bleeding. If you see this appearance in an elderly patient, then obviously one of the things you'd think of is an acute or a chronic subdural hematoma. So hematoma such as this is quite easy to pick up. What is difficult to pick up on imaging is when you have a subdural hematoma which is really thin, because what happens is because of the density of the calvarium abutting the subdural, it can be quite difficult to detect. So as in this example, I think you need to have a really close look to be able to pick up that thin subdural. So one of the things that we always do when we image is we look at slightly wider windows called subdural windows, about 40-400, and what that does is it kind of makes the density of the calvarium less intense, and you'd be able to pick out the small thin subdurals. Another thing which is really useful is now we have volume imaging on everybody, is to look at the reformats. Okay, so when we have unilateral, it's relatively easy because we're all quite used to comparing it with the opposite side and sussing out the asymmetry. But if there are bilateral subdurals, then that becomes really tricky. And not only let me rephrase this. It becomes even more trickier if the subdurals are isodense or subacute. So for example, let's look at this case. Here it is a little bit easier to see the subdural anteriorly because it is slightly more denser when compared to the cortex. So when I mean isodense or hyperdense, I'm talking relative to the gray matter. So it's slightly hyperdense. But as we go posteriorly and more or less over here, it becomes very difficult to see that there is a hematoma here and to see where the hematoma ends and where the brain starts. So these are difficult ones. Let's look at, so this is the same patient one section up. Again, because it is slightly denser here, we're able to appreciate the difference, but otherwise it becomes a little bit tricky. So one of the things that I usually suggest is, let me just get the pen, is to look at the sulci. Now, unfortunately, we can't see any sulci here. Well, suppose we could just see one sulcus. In a normal patient, the sulci should go all the way out to the calvarium. Okay, so over here, for example, it goes all the way out to the calvarium. When you draw the sulcus, and if the sulcus stops short of going to the calvarium, then you have to take a closer look for subdural. If you don't see any sulci, such as here, then the other thing I tend to do is look at the white matter arborization. And if you draw lines along the white matter arborization, you see that they stop short of the calvarium. So they're not going all the way out. That's another way to pick out these subdurals. Right, so let's go back. Sorry. Now, how does the hematoma look as the time goes by? So this is a 73-year-old lady who was imaged in our hospital serially. She presented initially with acute confusion following a fall. So what we see here, we see a left convexity subdural hematoma. So it is of a higher density, so increased density, concave inwards overlying the convexity, and then we see parafalcine extension. So we can see that if we look at the sulci, so this is what I meant by looking at the sulci. So again, normally you see the sulci going all the way out to the calvarium. If we look at it, there should be a sulcus there, there should be a sulcus there, it's stopping just short of. I mean, in an acute hematoma, you don't really need to do this, but this is just to illustrate how you can trace an isodense hematoma. Now, as the days went by, she was re-imaged a week later, and here it becomes a little bit more tricky. So we can see that more anteriorly, it is slightly lower in density. Now, this is what an isodense hematoma will look like, you know, very similar to that of the gray matter. So this is usually from in second week. As the hematoma matures and 3 weeks and more, what we tend to see is that it all becomes almost CSF density, not necessarily completely CSF density, but almost, and we see it as a low density extraaxial collection. So acute, subacute, chronic, and this is, you know, when she's finally drained. Okay, so this is just a table showing the different, you know, the time frame. Now, if you look at the literature, there might be a little bit of variability on how, you know, in the timing. So as in the number of days that people call it as acute, subacute, and chronic. What I tend to do is I tend to go more by the imaging. So if I see a hyperdense clot, I call it acute. I see isodense, I call it subacute. And if it's hypodense, you know, I akin it to a chronic clot. An example this time of a tentorial. So here what we're seeing is hemorrhagic contusions within the brain parenchyma, and we see a temporal subdural hematoma, and this time there is extension along the superior surface of the tentorium. So tentorial extension. So let's come to subarachnoid hemorrhage. Now, the most common cause of subarachnoid hemorrhage is still trauma. But usually, in the context of traumatic subarachnoid hemorrhage, it tends to be focal rather than diffuse, because here I'm you know, comparing with aneurysmal subarachnoid hemorrhage, which tends to be more diffuse. Then traumatic tends to be more convexity rather than basal. And again, we see in the context of traumatic subarach, the context is one thing, trauma, plus the associated abnormalities. So you may see subdurals, extradural, fractures, contusions. So look at the big picture. For example, in this patient, we see that there is fairly extensive subarachnoid hemorrhage within the sulci here. But then if we look at, you know, at least on this image, what we also see are parenchymal contusions with edema. So look at the big picture. It is quite easy to call subarachnoid hemorrhage when we see high density, which is, you know, unequivocal like this. But it can be really tricky as time progresses, because of what happens with subarachnoid hemorrhage is that it, at least on imaging, because of the CSF circulation, it can disappear really fast. The literature says that up to 95, so no, let me rephrase it. Now, CT, I mean, I know you're all familiar with CT negative subarachnoid hemorrhage, and on day one, it's said that the sensitivity of CT for picking up subarachnoid hemorrhage is 95%. Now with volume imaging and better scanners, I think it's slightly more than that, but it is not 100%. But as time goes by, so as you go to day 2, day 3, day 4, the sensitivity drops dramatically to the point that when you come to day 4 post subarach, the sensitivity might be less than 50%. So if we look at this example, it's very easy to miss subarachnoid hemorrhage, say for example in this sulcus and here. But if we look carefully, we do see a very thin pencil lining of high density along that sulcus there. And again, look carefully and we see high density in the sulcus here. So this is a slightly more trickier subarachnoid hemorrhage as opposed to the more evident one on the left image. So contusions, 2 types of contusions, hemorrhagic and non-hemorrhagic. Hemorrhagic ones are easy to identify. Non-hemorrhagic are the more difficult ones. There are 2 mechanisms. So usually, or the less common one, is when the head is not in motion and you see a depressed skull fracture. But the one that we tend to see a little bit more common is when you see acceleration and deceleration, as in the head is in motion and we see contusional injury. There are 2 locations. So you see coup contusions, which occur at the site of impact, and contra-coup when they occur diametrically opposite the site of impact. So what do we see on imaging? The common location tends to be where the brain is very close to the bone. So we look at the inferior, the anterior, and the lateral surfaces of the frontal and temporal bones. So these are common locations for contusions. If they are hemorrhagic, we see them as hyperdense, such as here. Now, this is a patient who's got contusions within the right temporal lobe, and we're also seeing quite, extensive contusional change, hemorrhagic contusional change in the left frontal lobe. There is also a small left frontal and also a tiny right frontal subdural hematoma here. Non-hemorrhagic contusions are very difficult to pick up on day 1. But as time goes on, day 2, day 3, once there is edema developing, then we can identify them. So a quick note on diffuse axonal injury. Most of the lesions in diffuse axonal injury are non-hemorrhagic and therefore very difficult to detect on CT. I mean, the literature gives 50 to 20%. In my experience, I would say probably about on the lower side, about 20%, tend to be hemorrhagic. And if they are hemorrhagic and evident, as in we are seeing here, so we're seeing one abutting the frontal horn of the ventricle, this is involving the anterior corpus callosum, another in the temporal. These are easy to pick up. But what can be very difficult is when they are non-hemorrhagic. But the locations to look for in the context of diffuse axonal injury is the gray-white junction, corpus callosum, notably the splenium and posterior body, brain stem, and the white matter tracts. So the internal capsule and the superior cerebellar peduncle are the ones which are described more in the literature. So these are the images of a patient who remained to have a low GCS, but the CT was normal on at least 2 occasions. So what I'm showing here are SWI images, and we're starting inferiorly and going up to the vertex. And when we look at the SWI, we see these multiple punctates. So we can see microhemorrhages here at the gray-white junction. As we go up, again, we can see like a linear dot, dot, dot of microhemorrhages occurring at the gray-white in the occipital lobe, in the deep nuclei, and as we go more anteriorly, these are in the corpus callosum, and here within the frontal lobe, these are multiple, in fact, numerous microhemorrhages at the gray-white junction, and this is what diffuse axonal injury would look like on MR. SWI tends to be more sensitive than gradient echo, and these are SWI images. A quick note on the grading of traumatic brain injury. This is the one that I tend to follow. It's a very old paper, and it's a pathological grading, wherein they talk about traumatic brain injury as mild, or diffuse axonal injury as mild, when we just see lobar hemorrhages. But once we see involvement of the corpus callosum, it's moderate, and when there is involvement of brain stem, it's severe. So it's a 47-year-old male here, GCS 8, not improving. And I've got axial images through 3 different levels. So we've got brain stem here at the level of the sylvian fissures and at the vertex, and the scan is normal. I mean, you have every image on this is normal. So what would you do next? So this is when maybe you could just type in the chat box and Tanveer can read out to me once there are about 4 or 5 replies. No?
So we have got a couple of answers. Almost everyone wants to do an MRI with SWI or gradient echo sequence.
Perfect. Thank you. So that's what I was looking for. So this is the same patient here. This is the gradient, and just to show you that see a lot more. So for example, if you look at it, there is hemosiderin here on the surface of the temporal lobe, and we can see a small microhemorrhage at the gray-white junction in the temporal lobe. The more we look, the more we see. So on the right side, again, we can see microhemorrhages here at the gray-white junction. There's one in the frontal lobe, and as we go up to the vertex, we're seeing again, microhemorrhages involving the superior parietal lobule. So multiple microhemorrhages, and this is just the tip of the iceberg. So if the clinical question is diffuse axonal injury, then the imaging modality of choice would be an MR, like you guys said, with either a gradient or an SWI, but I'd prefer an SWI. Okay, now this is a patient with a penetrating injury, and this was a shotgun injury, and we see the entry wound, the exit wound, and pretty much mushy peas inside. Hemorrhage, it's just pretty, I would probably say a lacerated brain through and through. And these are the bone windows, again showing the fractures and the bone fragments. Now the patient is not waking up. So what would you do next? Any answers, Tanveer?
Yeah, we got one from Dan Lewis. He suggested to do a CTA, and
okay.
And Sean replied to pray for the chap.
Oh, bless him. Right. Okay. Both of you are correct. What I didn't want in the answer is an MR. Okay. You would not do an MR in this patient. Why? Because see that really high density, tiny little fragment over there? That's a metallic fragment. And that is going to cause havoc if this patient goes into the MR scanner. Okay, so what I didn't want is MR. So I'm really glad that none of you suggested MR. And yes, I think CTA would be important because you want to see what the vessels are doing, and if there is any injury to the intracranial vessels. Good. Now, secondary complications. I mean, you're all very familiar with raised intracranial pressure, brain herniation, infarction secondary to brain herniation. Important thing to remember is infection, especially when you have penetrating injuries or when the patient has been operated upon. So that's the thing we're going to talk. Now, I know you've got a talk entirely on post-op brain, isn't it? So that's why I'm not going to touch more on infection here. A quick recap on this image that you've all looked at on Tuesday. So remember to look for the smile. Always look to see that there is CSF in the quadrigeminal and the ambient cisterns. And if there is, a chronic, so this is an acute on chronic subdural, and look for subfalcine herniation. This is how I measure the subfalcine herniation, looking at the displacement of the pellucidum from the midline. And also don't just stop for subfalcine, make sure, look at the rest of the basal cisterns, look for transtentorial and uncal herniation, and also hydrocephalus in this. So I'm not going to spend any more time on herniations, but remember to look at all the basal cisterns and to make sure that herniations are picked up. Okay, so we now, before we go on to spontaneous hemorrhage, there was just this one case I wanted to show. This was a patient who fell he fell down on his head. okay, and came in with a GCS of probably 6, I think. I mean, I don't remember exactly, but quite a low GCS. Looking at the non-contrast CT, there was really nothing below this level. And as we start looking at the images up, what we see is that, yes, there is calvarial injury here, and we see subgaleal hematoma, and there is also what looks like, you know, a little bit of blood just below the calvarium. But what I'm trying to say is that the axial images really underplay the extent of injury there is. So if we now look at the bone windows, what we see is, you know, fairly extensive comminuted fractures with sutural diastasis here. And the reason this is an important case, more from a learning point of view, is that when the abnormality is in the axial plane and we are imaging in the axial plane, it is very easy to underestimate the extent of imaging. So it's really important to look at the other planes. And if we see in this patient, he had a massive extradural hematoma. And fortunately or unfortunately, he's decraniectomized himself, you know, because the cranium is lifted up, we're not seeing much mass effect, and that's why we're not seeing much on the axial images. But this is quite a devastating injury with a potential to injure the superior sagittal sinus here. So remember, it's always important to look at other planes, especially when there is a clinico-radiological apparent discrepancy. Okay, so let's move on to spontaneous hemorrhage. Now, spontaneous hemorrhage, you know, by definition is non-traumatic hemorrhage, and depending upon what the underlying etiology is, it can either be primary, as in if we have small penetrating vessels that you know, are damaged because of hypertensive lipohyalurosis, you get a hypertensive pattern of hemorrhage. Or if we get, you know, small hemorrhages that because of amyloid deposition, and again rupture of vessels because of amyloid angiopathy, then we can get a spontaneous hemorrhage. So there are two important things to remember in the context of primary spontaneous hemorrhage, which are hypertension and amyloid. When we look at secondary spontaneous hemorrhage, if the patient is young, by far vascular causes tend to be the more common. And by vascular, we mean aneurysm, AVM, cavernoma, venous sinus thrombosis. Neoplastic is another important thing to remember. Metastasis such as renal cell, thyroid, breast, and lung. Or you can see it in the context of primary tumors such as GBM, ependymoma, pilocytic. Also we can see hemorrhages and anaplastic. Other causes is vasculitis, especially when you see hemorrhages and infarct simultaneously. Got to think of vasculitis, and not to forget drugs. By drugs, I don't mean just, you know, substance misuse, but I also mean patients who are on anticoagulants, so antiplatelets and anticoagulants. So that's just a brief overview of the etiology of spontaneous hemorrhage. How do we see it on CT? So like any hemorrhage, an acute hematoma, we're going to see it as a focal lesion, which is high density on CT. In this context, we can see that it has dissected into the ventricles. So we're seeing a layer within the occipital horns, and we're seeing blood within the third ventricle. Again, we can have fluid levels even in intraparenchymal bleeds, and that depends on whether it has yet had the time to clot or not, so as in active bleeding, and in the context of patients who are on warfarin, so anticoagulants. So I've taken you through the slide. I'm just showing it again just to say that the way the hematoma evolves is very similar to what we have seen in the context of extradural and subdural. So hyperdense, then isodense, and then hypodense. So on CT, it's very straightforward. But if you were to look at the appearance of hemorrhage on MR, it is quite complex. Now, you as neurosurgeons are not expected to remember this slide. The radiology trainees, however, have to remember it because it tends to be a very, you know, a very common exam question about the appearances of hemorrhage on MR. And the thing, because you see, the reason we see such a varied and such a complex pattern is because on MR, we can actually image the hemoglobin breakdown. So in the context of acute or in the context of hyperacute hemorrhage, when we still have oxyhemoglobin, the signal intensity tends to be usually low on T1 and high on T2. But once the oxyhemoglobin starts changing to deoxyhemoglobin, the signal intensity changes. And again, depending upon whether the methemoglobin is intracellular or extracellular, the signal characteristics change on T1 and T2. So this is quite a varied picture on MR. Now let's go back to hypertension and hemorrhage. The most common cause of stroke is in fact ischemia, but in about a small proportion, I think about 20% or so, you do see hemorrhage, and if you see hemorrhage, that's a contraindication to thrombolysis. Usually when we see hypertensive hemorrhages, the common location tends to be deep gray nuclei or striatocapsular in location, and this is what I mean by hypertensive location. The next common tends to be thalamus. We can also see hypertensive hemorrhages in pons and cerebellum in about 10%. And lobar can occur in hypertension. So just because a hemorrhage is lobar, don't exclude hypertension as a cause. So in this example here, what we see is a thalamic hematoma. Again, it's dissected into the ventricular system. So we see blood in the occipital horns bilaterally. So the pattern that you guys probably more commonly encounter with is this, so which is an acute hematoma that is in the deep nuclei or thalamus, pons and cerebellum. But we can also see another pattern of hypertensive hemorrhage, and that is when we see microbleeds. And microbleeds typically occur in the deep nuclei, and this is more an MR diagnosis. So for example, here in this patient, so this is a different patient, this is a gradient echo sequence, and what we're seeing here is an old hemorrhage within the lentiform nucleus. Because it's old, there is no longer any mass effect to it. All you're seeing is a collapsed hemosiderin lined cavity. But if we also look carefully, we see these tiny dots here, 1, 2, 3. Now these are microhemorrhages, and this is the typical location where we see hypertensive microhemorrhages. But please do remember the difference between the spontaneous hemorrhage, which is occurring because of a rupture of a small penetrating vessel, as in here, versus hemorrhagic transformation in an infarct, wherein you have an infarct to begin with, and either because of spontaneous reperfusion and leaky bed, or because of treatment, as in thrombolysis, we see a hemorrhagic transformation in an infarct. So these are different entities, and it's important not to convince between spontaneous hemorrhage versus hemorrhagic transformation in an infarct. So what is my approach to spontaneous hemorrhage? I usually, have two questions. You all must now be familiar with my two-question pattern. So two questions. What is the age of the patient? And is the patient a known hypertensive? I think, and these are two relevant questions, and I will take you through my thought process, how I look at the scans. So once I know these two, then I look for clues on the CT scan. So where is the hemorrhage? Is it deep nuclear or is it a lobar hemorrhage? What is the pattern of the hemorrhage? And what I mean by pattern, when we look at the next cases, we can go through this. Is there any calcification? Is there any calcification at the margins of the hematoma? Is there any calcification that you can see in the area of hemorrhage? And finally, what is the pattern of edema at presentation? So usually you see when patients present with a focal neurological deficit, they pretty much get imaged the same day now, or pretty soon. But if we start seeing edema at presentation, then we need to be a little bit more cautious in reading it. So those are the three things that I look for. And before I go further, I just wanted to convey two things to remember. That hypertensive bleed does not just occur in the basal ganglia and thalamus. Now I've mentioned this in a couple of slides ago as well, that it can occur in the posterior fossa. And remember, 10% of hypertensive hemorrhages are documented to be lobar. The other thing I want to say is that, having said my first statement, not all basal ganglia bleeds are hypertensive. Okay, this is an important thing to remember. It is important not to dismiss every basal ganglia bleed as a hypertensive, because if we look at the literature, and this is a good paper in AGNR, we see that the literature varies from 2 to 4%, and I've put about 4% here. We can see a secondary cause. And for me, if the patient is not a known hypertensive, or if the patient is a young patient, then I would think twice before labeling it as a hypertensive bleed. Okay. So this is my approach. What is the age of the patient, and is the patient known to be a hypertensive? So when we then look on the hemorrhage on CT, if it looks like a cavernoma, and we'll look at a couple of examples where I'll tell you what I mean by saying if it looks like a cavernoma, then the next step would be an MR brain. Okay. Now, on the hemorrhage, when we look at the pattern of hemorrhage on CT, and if it is in a typical location that we've discussed in a known hypertensive, then that's it. I think that's where the imaging pathway ends. But if it is not a basal ganglia or a thalamic bleed, or if the hemorrhage is in a patient who is not a known hypertensive, and if there are other additional clues on CT which could suggest a vascular cause, then the investigation of choice will depend on whether we think the vascular etiology may be arterial, in which case we do a CTA, or venous, in which case we do a CTV. Sometimes, if the CTA is negative, or if it is positive in certain cases, we can then proceed with a catheter angiography. If, on the other hand, the pattern of hemorrhage on CT shows significant edema surrounding the clot, which would be unusual for a day 0 clot, then you would be thinking of an underlying neoplastic etiology. And in those cases, our protocol at least is to do an acute MR. Now, the acute MR may not necessarily help because there is a lot of blood, and so we may not see the actual lesion underlying it, but what it could explain or what could help is to see if there are other similar looking lesions in the brain, such as metastasis in the context of, breast or renal cell, or cavernomas. So that's how the acute MR helps. But most of the times what happens is that, we may not pick up an underlying etiology, and the patient then goes on for a delayed MR. So let's look at some examples. This is a 39-year-old coming in with sudden headache, left-sided weakness. The primary abnormality that one identifies readily is the fact that there is a big frontal lobe hematoma. So lobar hematoma in a young patient. But then if we look closely, we also see it's not just lobar. We see that there is blood in the basal cistern. So there is subarachnoid hemorrhage, and there is this rounded lesion that we are seeing in the anterior interhemispheric fissure. So put everything together, our next step of investigation would be a CTA. So we've got a young patient with a lobar and a subarachnoid hemorrhage. There really is no argument here. So we do a CTA, and what we see here is an anterior communicating artery aneurysm. So let's look at another case. So this time we have a 50-year-old with sudden severe headache. We don't know if the patient is a hypertensive or not, but the imaging gives clues. And the clue is that the hemorrhage is diffuse and fairly extensive within the basal cisterns. And in this context, especially, well, if there is subarachnoid hemorrhage, which is diffuse and basal, and in a pattern where you're seeing more basal blood than convexity, we do tend to do CTA to make sure there is no aneurysm as the cause of it. And in this patient, what we're seeing here is an Ica aneurysm, which is the cause. You can actually see the aneurysm here on the non-contrast CT, but I can see that this could be also interpreted as a hemorrhage, you see. So it's difficult to call this as an aneurysm on the non-contrast CT, but the CTA clearly shows the aneurysm. Another patient, so this time a 64-year-old male with acute left-sided weakness. Okay, age slightly older, acute presentation. If we look at the non-contrast CT, what we see is a lobar hematoma. So frontal lobe, we see that it has dissected into the lateral ventricle, so there's a little bit of blood in the occipital horn. Not really that much edema surrounding the hematoma, but there is a clue on this CT wherein I see a tiny focus of calcification at the edge of the hematoma, which is just here. I hope you are able to see it as I am, but there's just a tiny focus of calcification there. So there are two things we think of in this context. This is a lobar hemorrhage, so it's not a typical hypertensive location. And I don't remember whether this patient was a hypertensive or not, but given that the CT actually shows calcification, even if the patient was a hypertensive, I would want to, image this further. So the question is, do we think it is vascular or do we think it's neoplastic? With the acute presentation, the first thing and the way that we see the calcification, I would want to make sure there is no vascular malformation. So this patient had a CTA, and what the CTA shows here is a nidus of vessels just at the margin of the clot, and this is the catheter image showing you an AVM. So this time lobar hemorrhage because of an AVM. Another case, so 51-year-old female, acute speech problem and headache. So we've got non-contrast CT, and if you look at the pattern of hemorrhage, so we see lobar hemorrhage, but you see this pattern is very different to the hemorrhages that you have seen so far. And what we're seeing in this is quite a variegated appearance. So it's not like one, it's not like one blob of high density. This is just, quite a variegated appearance with areas of low density and areas of hemorrhage. Okay. You just have to take a moment back and look at this and ask yourself, what is happening here? Is this an infarct with hemorrhagic transformation, or it's such a heterogeneous area of ischemia? It looks like ischemia and hemorrhage. Could it be venous? And then the clue is actually on the CT itself, where you see this focal high density in the region of the sigmoid sinus. And that is enough for us to help in the next investigation. And what we would do here is a CT venogram. So these are CT venogram images. We can see contrast within the normal transverse sinus on the right. And here we see that there is a non-filling of the sigmoid sinus on the left, and this is venous sinus thrombosis. And the reason this patient has had a hemorrhage within the temporal lobe is because of the vein of Labbé being involved. So next case, this is a patient presenting with acute confusion. This is a CT done, at day 0 of presentation. And what we're seeing here again is a lobar hemorrhage. Okay, so not a typical hypertensive location. And another important thing to note is that look at the edema surrounding the lesion. There is far too much edema here for a day 0 hematoma. There is also a bit of mass effect, and we can see just about a little bit of distortion of the frontal horn and the corpus callosum. So the concern here is that of an underlying neoplasm. So we did do an acute MR, but unfortunately, because the extent of hemorrhage that we see, so what we see here is an axial T2 sequence, this is an axial T1 sequence. We can see that the center of the lesion is high signal intensity on T1, on T2 and T1. So this is extracellular methemoglobin, and the margin of the lesion, is beginning to be low signal intensity on T2. So a hematoma, but a fair amount of blood products here, and therefore we really couldn't pick up anything abnormal. So what we then did was we got her back, and she actually had imaging at 8 weeks, which also was not helpful, and then ultimately had to have repeat imaging at about 11 to 12 weeks. And this is when what we see is whatever all that hemorrhage is, that has resolved, and on post contrast we see a ring enhancing lesion. And actually the diagnosis of renal cell was subsequent to the MR imaging. So it was not a known patient with a malignancy. So this is just to show that sometimes the imaging can take time, and especially if the context is that of a neoplasm, then MR would be the modality of choice. I'm just showing you so that was the T1 at the time of hemorrhage with a lot of high signal intensity because of methemoglobin, and this is T1 when all the methemoglobin is now gone, and what we can see is the enhancement of the lesion. Moving on to amyloid angiopathy. So in the elderly population, the most common cause of a lobar hemorrhage would be amyloid. Usual presentation, can that be of a lobar hemorrhage, or you can have microbleeds. This is an axial T2, and this is an acute hematoma. So we can see it's low signal intensity on T2 with surrounding edema. And the other pattern that we can see is that of microbleeds. They can also have associated white matter disease. And very rarely in amyloid, we can have a non-hemorrhagic, but an encephalopathy, as in an amyloid angiitis type of a picture. This is the gradient echo sequences in another patient with amyloid, and this is the pattern of microhemorrhages that we see in amyloid. So numerous microhemorrhages, we can see that they're all lobar. Nothing in the deep nuclei. So if you remember, I showed you a hypertensive bleed where we see hemorrhages within the deep nuclei, whereas in amyloid they tend to be more peripheral or cortical, and again quite extensive within the occipital lobes and temporal lobes as well. How are we doing for time? So 10 more minutes. So this time a 29-year-old vomiting and confused. Okay, so we have non-contrast CT images here, and we see hemorrhage involving the midbrain dorsally. Likely mass effect on the aqueduct. We're also seeing hydrocephalus with dilatation of the lateral ventricles. This is a difficult one. It's a young patient with a brainstem hemorrhage. And I think the differential here, could be anything, to be honest. It could be vascular, it could be neoplastic, it could be vascular, as in a cavernoma. So I'll show you the images on this patient. So these are axial T2, T1, and gradient echo images. And what they show is this popcorn type of lesion involving the thalami, which is high signal intensity internally on T1 and T2 and has this low rim. And this is a typical appearance for a cavernoma. On the gradient echo sequence, because of repeated hemorrhages that occur, we see blooming, and there is also, patient has also had subarachnoid hemorrhage, which is why all this pencil lining that we see, the low signal intensity, is a hemosiderin on the surface of the brain stem as well as on the PL surface and cerebellum. So this is somebody with siderosis because of repeated bleedings from a cavernoma. Another example of a cavernoma, this time is an incidental pickup, would be again a popcorn type of a lesion abutting the frontal horn, internally high T1 signal intensity with blooming on the gradient echo. So just a short note on cavernomas, because cavernomas are common incidental lesions, and I'm sure you guys keep getting called again and again for a radiology report mentioning a cavernoma. These are actually hematomatous lesions formed by sinusoidal vascular spaces, but there is no intervening brain parenchyma in this lesion. Mostly solitary. If there are multiple, you have to think about familial or ask for a history of radiation. On CT, high density with or without calcification, but the imaging modality of choice is MRI. Okay, these lesions are angiographically occult because they do not connect to any vessel. So the imaging modality of choice is MR, where we see a popcorn type of a lesion with heterogeneous T1 and T2 signal intensity with a hemosiderin rim. And sometimes you can see an associated DVA, and it's actually very nice when you see an associated DVA because this is a common association with a cavernoma. So this is an interactive case. So we have a 25-year-old pregnant woman, came in with severe headache, nausea, vomiting, and had respiratory arrest on the ward and had to be intubated. Okay. So she had a CT for obvious reasons, and this is what the non-contrast CT shows. So I'll show you the images there, and I won't talk you through the images, but what would you do next? So if you type in the chat box,
so everyone's answer is CTV.
Oh, excellent. That's brilliant. Thank you. Okay, so what we're seeing here is hemorrhage within the cerebellum. Okay, again, remember patchy, a variegated pattern of hemorrhage. Because this is a posterior fossa hemorrhage, mass effect, fourth ventricle is completely gone, all the posterior fossa cisterns are effaced. And remember, there is an upward transtentorial herniation. We've got a little bit of a chubby cheeks going on here because of the hydrocephalus. But the clue is to look at the rest of the images. There is increased density here, which may be a difficult one. You see, you might wonder over, is this just part of the hemorrhage or is it the sinus? But as you look higher up, you see that there is increased density of the sinus. And this is where you would do a CT venogram, and the CT venogram clearly shows fairly extensive thrombosis of the superior sagittal sinus. Part of the torcula, the left side is okay, and then all of pretty much of the right transverse and sigmoid sinus. So venous sinus thrombosis. I put this slide in because I knew there's going to be more neurosurgeons than neurologists here. It's an uncommon indication of stroke, but nevertheless, a very important one not to miss. Risk factors postpartum and pregnancy, more so in postpartum, and underlying thrombophilia. Headache, they say, is nearly universal at onset. In a small minority, you can have a thunderclap headache, but seizures, for me, seizures is alarm bells, and I'm very careful when I'm given the history of seizures. And on imaging, CT is the imaging modality of choice initially, and depending on what the CT shows, CT or MR venogram. At our institution here, we prefer a CT venogram because you see we can do it at any time of the day or night, and it's fast and it is really good. MR venogram can be useful, especially when there is a focal deficit and you're trying to evaluate what the underlying brain parenchyma is like. But usually getting this out of hours is tricky. Okay, so by far we go more with a CT venogram. Another case, this time is a 61-year-old with frontal headaches. You see, I'm being very generous with you guys. We never get such a detailed history. All we get is probably headache, query bleed. But I'm being very generous with you, so I'm giving you all this story, so you need to get the diagnosis. Frontal headaches for 8 days, treated for sinusitis. Okay, and the patient came in with headache, nausea, vomiting, and diplopia. So gets a CT scan, and what the CT shows here is hemorrhage within the prepontine cistern. And what would you do next? I think I'm running out of time as usual, so I need to speed it up a bit, but we're almost there. So what would you do next?
So again, the general consensus is to get a CTA angiogram.
Good. So that's what you have. This is a CTA. And what I've shown is just volume rendered images, just so that I can show all the vessels in one go. We see that there is very severe narrowing of the basilar artery. There is also multifocal areas of narrowing of the PCA bilaterally. Supraclinoid ICA bilaterally are narrowed, so as the ACA and MCA. So what we're seeing here is a diffuse multifocal narrowing, no aneurysm. Because of the location of the hemorrhage, patient also had a catheter angiogram, which was negative. But I'll show you the rest of the images. So this is at presentation, and this is at follow-up. So what do you think the underlying diagnosis here is? So go back to the history. I think the history is important. This was a patient who's had headaches for a few weeks, was treated with sinusitis. And what I withheld from you is that the patient had nasal decongestants for sinusitis. And this is somebody with Rcvs. So reversible cerebral vasoconstriction syndrome. Finally, I'll take you through this, and I was going to ask the question, but I think I won't now. This was a 56-year-old coming in with seizure. So what we have here is a T2, flare, post-contrast T1, and DWI. And what we see is a lesion within the frontal lobe with restricted diffusivity. Okay. Now, it is very important, and this is one thing if you take away from this, I'd like to take away that everything that shows restricted diffusivity is not an abscess. And I know, especially for neurosurgeons, you get referred scans for query abscess a lot. But remember that when you see restricted diffusivity, it's always important to look at the whole picture, because in this patient, if we just look at the post-contrast T1, it's very easy to mistake this to be rim enhancement, whereas in effect, this is just extracellular methemoglobin because of hemorrhage. And this patient, CT, clearly shows that this is a subacute hematoma. Okay, so really important, don't just rely on DWI when you're asked to look at MR, you have to look at all the sequences and previous or subsequent imaging. Another case here, this time this patient came in actually with vague symptoms, and I remember very well because the first imaging investigation he had was an MR because they were querying demyelination. And we see this focal lesion here within the peritrigonal white matter, and one wonders, oh, is this an acute demyelinating plaque? And it is very easy to miss on the T1, the asymmetry between the lateral ventricles. So here you can see the normal CSF in the trigone, and there is effacement here, but it is so easy to miss it. If we then go back and look at the CT was I rephrase, not going back. This patient, we then asked for the CT to be done because the imaging, looked suspicious. You can actually see very easily that there is hemorrhage. All I'm trying to show here with these two cases is that hemorrhage on MR is a difficult thing to pick up, whereas it's so much more easier on CT to identify hemorrhage. So to summarize, intracranial hemorrhage, I usually look at it as either traumatic or spontaneous. CT remains the initial modality of choice. In spontaneous hemorrhage, when we work up the underlying etiology, I tend to rely on age, the risk factors, and the CT appearances to try and decide what the next step is. So this is my pathway. So this is my approach to looking at or suggesting further assessment of hemorrhage. Remember that it's very variable as to what we use, whether we use CTA or CTV or MR, but we shouldn't do everything. We need to try and rationalize. And there are clues both in the clinical history, the imaging presentation, as well as CT to rationalize and do what would be the most appropriate modality. So that brings to the end of the talk, and it's 10 o'clock. Any questions? What I'll do now is, let me just, I need to minimize this, isn't it, to be able to see the chat box. Let me just minimize. Discard. Okay. So any questions? Happy for you to unmute yourself and ask if there are any questions that you have. Okay, let me see. Go all the way to the top. So do you have... Oh, so I think I answered that question, isn't it? One of the questions is, do you have any criteria that prompt you to consider vascular imaging in an intracranial hemorrhage? Age, anatomical location, characteristics of the hemorrhage itself. So it looks like you've preempted the second half of the talk. So are you happy with that, or any more questions on that? Is it Cathal? Oh yeah, fine. Okay. Now any other, let me see. Yeah, I think some of you mentioned perimesencephalic for that prepontine hemorrhage, isn't it? Yes, I think that is one thing that you would think of. But on the CTA, when you see such diffuse vasospasm, perimesencephalic hemorrhages don't cause diffuse vasospasm like that. Okay, so when you see diffuse vasospasm like that, it's really important to make sure that there is no aneurysmal cause, which is why the patient went on to have a DSA to make sure that we're not missing an aneurysm on CTA. And then the other thing that you keep in mind, obviously, with multifocal multivascular narrowing is vasculitis and Rcvs. And that patient turned out to be Rcvs. Okay, one of the question is, in case of subarachnoid hemorrhage and epidural hemorrhage, please explain about the hemorrhage crossing the suture and crossing the midline. Okay, I don't think subarachnoid hemorrhage, I don't think I think you're probably asking more about epidural hemorrhage. So because of the way the dura is attached, now when we see epidural hemorrhage, it is occurring because of a vascular injury, usually an arterial injury, so under pressure, which strips the adherent periosteal layer of the dura away from the calvarium. Okay. Now, because the periosteal layer of the dura is invested, it's completely adherent at the suture, it becomes really difficult to strip that off the sutures. That's why they don't cross the sutural line. Does that explain? And in terms of crossing the midline, so again, because how the dura, now because it is epidural in location, it is not reflected. It is not going to be reflected along the forks. That's why it is not going to, it can cross the midline. It doesn't have to turn medially in. Is that reasonable, or? No, I mean, you can unmute yourself, and I'm not hearing anything here. Okay. Now, how do you distinguish between a chronic subdural and a hygroma? On CT, it can be difficult because just measuring the CSF density might not be helpful. On MR, yes. So if you see on MR, if it is a hygroma, it has to be iso-intense to CSF on all sequences. Whereas if it is a chronic subdural hematoma, it will not be iso-intense to CSF on all sequences. You can see high signal intensity on flare. You will see susceptibility on either gradient or SWI. And you can even see if it is a subacute hemorrhage, then you can see high signal intensity on T1. So more easier to distinguish on MR than on CT in terms of chronic versus hygroma. Is there a way to reliably distinguish between Rcvs and vasculitis on imaging alone? It's a great question, and that is something that I am very much interested in. So lately we've got, or at least in the last 4 or 5 years, there is increasing use of intracranial vessel wall imaging. And what we are looking at here is you're looking at not the consequence of what is happening. So you see, when we see narrowing on CTA, what we're looking at is the consequence of the underlying pathology. So you can have narrowing because of a number of causes. So that's why CTA won't be able to distinguish between the two acutely. Whereas if you look at vessel wall imaging, you're going to look at the wall of the vessel, and in vasculitis, you're going to see inflammation in the vessel wall. And that is how you can distinguish between Rcvs and vasculitis, because in Rcvs, you will not see vessel wall inflammation. All you're going to see is spasm, which will be non-enhancing. So vessel wall imaging is a good way to differentiate, in my opinion. So I think that's the end of the questions. So if you don't have any more questions, we can end there. Okay, brilliant. So Tanvi, do you want me to end the meeting, or are you happy? Or
Yes, that should be fine. Thank you so much, and thanks everyone for joining.
Okay, thanks a lot. Bye.